Sì, benissimo. Tra l'altro aver lanciato il sasso nello stagno dei parametri ha scatenato poi
we talked about parameters. This has been provocative. A lot of questions during the coffee break. How much you use these and how much you use that. That's a hot issue. I was very pleased to talk to my colleague who is going to talk about cellulitis, Dr. Cali Terme, who said, absolutely, we're just in line. I never met him. I didn't know he was a big expert. And we take the same approach for the machine setting, something that makes you possible to customize. For the machine setting, identify typical patients, so thin skin, so thin tissues, and no fat. So in these situations, so we have to preserve a minimum amount of fat. Parameters mean 2.5 watts for power, 25 T on and 50 T off. So pulse.
Tessuti pelle più spessa,
thick skin, but once again without adipose compartments, no fat. Sorry.
In questo caso i
So
watt
this
rimangono gli
time,
stessi,
the same watts.
allunghiamo un pochino il T-on, quindi
So
passiamo
more T-on
to
to 2.5 watt from to 25 to 40 milliseconds and T-on 50.
Questo è quindi il secondo, la seconda tipologia di
That's the
paziente.
second type of patient.
Tessuti
Third type of
pesanti,
patient, a thick
grasso
skin
rappresentato.
with fat this time.
Nella mia esperienza,
In my
non
experience,
ho un dato
I have no
scientifico, nel senso che non ho
scientific
dei
data.
darvi
I have no
soltanto,
histological findings. I can just give you a general review of more than 1,000 procedures over 3 years of time. The gut feeling, empirical gut feeling, lipolysis starts around 50 milliseconds, up to 75, up to 100 milliseconds. I just use for huge, big adipose compartments for the body. Under 50 milliseconds, skin tighten 40 milliseconds, going to melt more than 25 milliseconds. You don't turn on at 50. These are sort of logically fed, gradual, so you can just modulate the lipolysis you want to get. So Dinko just told me, Dr. Carly Turner told me the same values. So not just clinical observations, it really works. On the average, how many joules? Good question. You know, we have no average value. I can tell you, honestly, in a jaw line one side, around 180 joules, we start seeing something. But in some patients, just to speak of one side jaw line, 250, 300, 400 and 500 joules even, because we want to get some clinical evidence of good results. But that's subjective. So you have patients at 200 joules for one side. I see good results and then stop. For other patients, they take more time to get good results. Now we have to be clever, more clever in making a good setting of this method, this technique. I do not believe it's just the patient's response that counts, but also, so if the tissue is fibrotic, more or less fibrotic, the adipose lobules and adipocytes. So we have many things to take into account in order to be more accurate when setting the machine. 170, 200 joules for the beginning, but not more than 400 and 500 joules for one single side. out of mic, we can't hear. So the total fluence. So these are the cases, you know. So if you just have the jaw line, the area going to treat is more confined. Now you have to go downwards. So the region becomes bigger in a face like this one. Also, we go up to 1,500 joules totally of the two sides plus the neck, which was unbelievable in other types of patients like that one or this one. So it's hardly done. You can go over than 800 joules totally. So the presence of fat affects the target to achieve. Robbie, you agree? Do you want to elaborate on this? Okay, good, perfect. Now we switch to the neck now. The same applies. Now you see, don't you? That's something, and we would agree with Dinka. I agree with Dinka. You're going to change the setting according to the area. So jaw line, so lateral side. I insist with the chin on slightly higher, the tissue thicker. I go to the chin. I go down with chin on. I go down to the neck. I put this up. I do the area under the chin. I go to 70, 80 milliseconds for T on because the tissue is slightly hard, fibrotic. So it is not the setting per patient, but also a setting per area in the same patient. And you have to mark down the areas where we want to use different settings in order to be helped for making the treatment according to the skin compartments. So neck, thin skin, no fat, watts, the same watts, 2.5 watts. With this time, once again, T-on is more elongated because the skin under the chin is more, is more resistant, is stronger. So the response is not so quick. So 25-40 milliseconds. And also more bulky tissues up to 3 watts, up to 50 milliseconds, up to more demanding situation, thick skin and fat, and this time watts go up to 4 watts and T-on from 50 to 100 milliseconds. So during the setting, so also we have to take stock with the patient's comfort, and when you have to deal with these cases, you have to ask yourselves, shall I do some local anesthesia or not? So I just leave the pure concept of Endolift and switch to something else, which is a sort of laser lipolysis. That's true. It's for doing this, just increasing the patient's comfort to go beyond the line, because the situation is different now. I don't remember if I included this slide in my presentation now, but sometimes I do some local anesthesia with a small syringe. I just take some oil out, causing inflammation, and that's something I suggest all of you. I recommend also for those not being surgeons, we have to suck gently, use very small cannula. So for doing this better, like a lipofilling cannula. It's very easy, it's quickly done. This really helps us because this oily matter also gives rise to some inflammation and extending the recovery time per se. Body. So 200 micron fibers. I use these fibers not a great deal on the face. I don't use them for the body, but for the knee, where you wanted to get some skin tightening, small radial wrinkles around the knee. This works quite well. So the colleague working with me, Domenico Romano, working in my office, he already met Domenico Romano, and he really loves the 200 fiber for the knee. So even though it tries to, to get out of your hand with the low energy emission, so this fiber is very effective in a way, very well performing. So absolutely we suggest using this fiber. I use and I suggest the 300 micron fiber from 2.5, 3.5 watts, T on lower than 50. If we just speak of skin tightening very often for the body, we need some lipolysis. So T on up to 50 and even 100 milliseconds with 400 micron cannula. I always use some local anesthesia, some very delicate client. I need no anesthesia, complete anesthesia. It's enough just to desensitize, even though we're regions not hit by anesthesia. It's not really painful. So the patient said, I felt a sort of pinch. That's good. So I do not do any tumescent anesthesia. It's not a liposuction. So, yes, exactly, correct. Because once again, I wanted to have our colleagues' opinion. That's a doubt I have. I've got troubles. The increase of water in the tissue, this increase, yes, you got me right. Is it a benefit or is it not a benefit, increase of water content in the tissue? If we do an infiltration, it's much better to let this rest 20 minutes for the possibility of a sort of imbibition of the major tissue. It's not interstitial water, it's a sort of hydration. If there is too much interstitial liquid, so we have a change of the target, we have energy dispersal, and vice versa. You have some latency period that makes it possible a better spread, the diffusion of energy. This can be a real advantage to exploit, but I want to get your opinion as well to this extent. It's important to get some latency time. Very often I put some ice where I did anesthesia before the treatment, lipolytic treatment. What's difficult? The difference is the quantity of tissue to treat. If we want to treat a bulky tissue with some fat, you try to diffuse this energy, and so you can do a real tumescent anesthesia. And sometimes the dry anesthesia very light, in order to reduce the effect of energy dispersal. Riccardo, I have to thank you and Roberto for my approach to Endolift. I knew thanks to your suggestions. Thank you so much indeed. And also to personal experience. On an exchange of views, if you increase the watts, you have to do the anesthesia because the patient cannot stand this. So the endpoint, that's important, I really like, because I just crossed the red light of the traffic light, and I've seen that in reality the worst result was because I got this fat and I insisted in doing this, and so thanks to this strong inflammation I created, there was the formation of a plaque lasting months and months. So that slide very interesting with the traffic lights. So that slide gives you the idea where you have to go to get brilliant results. Yes, you got me right, because the threshold between stimulation and damage is very, very small. So the more you give the stimulation, and the more response will be released. There is a sort of destructurization of the tissue. You're going to inhibit the response. And this applies to the body as well, also for the ankle. If you insist on the ankle too much, it's really detrimental. So you spoil the results. For the ankle, when you see some results, see the ankle, so it is clean and dry, stop there. Because the inflammation recovery process takes long, and this can also put into jeopardy the results. Yes, for the ankle, you're right. Did you have any problem of lymphatic drainage? When I force too much? Yes, because the ankle is very delicate for the lymphatic drainage. Yes, I got problems. So I went backwards and I reduced a lot. But also for some phases, it's very important having a good control. Intra-op control is key. We have patients coming to me so quickly, and so the inflammation shows up quickly, and then we have to stop. We have to say the client and the patient, we have some individual limits. If the patient is prone to inflammation, we have to start much earlier, because you can't cross the road when the color is yellow. You have to stop, like before the traffic light. So we have to tell the client your tissues doesn't make it possible to go beyond. Maybe 2 sessions. We're going to treat you once again after 3 or 4 months. So we should take some break. 2 or 3 months between one session and the other. 2 or 3 months, not earlier, because we have sort of cumulative damage effect, but also some individual limits. 1,700 joules for their face, pretty well done. At 600, 700 joules have to stop. But that's important to have some experience and skills. But those markers are used, are easily controlled. You see, erythema immediately changes of intensity when it starts being really inflamed. And that's the first. The first point not to neglect. That's the first step. Something also interesting. Patient's education is key. We have to tell the patient, before 1 month, you're going to see nothing. You're going to worsen. Don't tell me. After 1 month, you're going to improve. First, you're going to worsen, then you're going to improve. But after 1 month, that's really true. We stop making any check after 1 month from the method, from the technique. So we have no expectations. I don't want to see you back after 1 month. You're going to be worse. That's a clear point to tell to the patient. Of course, we have to monitor the patient. So we do the patient, and then we keep on monitoring the patient coming in and getting out of our surgery, and then we have just a special chapter about home care. And these belongs to the general patient's management and work out. But let's take pictures. We will take pictures at 30 days, so the patient is going to be deceived, disappointment. And the patient is disappointed. After 2 months, it's going to be beautiful. After 6 months, it's really beautiful, fantastic. So the first photographic check has to be done after some time, not before 30 days, after 2 or 3 months. Sorry, no mic, we can't hear. So complications, I already said. I skip complications. What shall I do? You're going to talk, are you going to talk about complication, ecchymosis, hematomas, erythema, edema, subjective pain, tingling? So, I'm showing you these complications. I got two neuropraxia of the marginalis, one temporary, one solved in 10-15 days, one more time-consuming, but the 2 were totally reversible. These are the types of wear and tear and alterations to the fiber conductivity. So top high, you have the release 100%, emission 100%. The second deformity, irregular, is due to some wear and tear due to the impact on the tissues. You see more fibrotic tissues with some scarring, so, and also tissues that have been previously treated with surgery. So the tip of the fiber is worn more quickly, more wear and tear, and so the tip has to be substituted intra-op. So no more sliding, doesn't slide in so well, no more smoothly. I put the tip on the glove, and if the energy emission is not so well defined and sharp, maybe the time has come to change the tip of the fiber, and Well, so the good laser light emission seems to affect the result. If the tip is like a mean lens with some light diffraction, the wavelength is going to change. You get inflammation, do not achieve the biological targets. So it's not just that it doesn't work so well. No, maybe it gives more harm than good. So we have to bear this into mind. Opacification also belongs to wear and tear, and also carbonization the same. And now you see the right image, so the possible breakage of the fiber or discontinuity of the fiber. And you see this because when you just connect the fiber, you see some dots of light on the path, even though it's nice looking and also suggestive. So there is energy dispersal, so the fiber is not compact. You test these once again, but if you see these fibers with some light dots, it's not a continuous fiber, so you have to substitute the fiber right away. Okay, here we go. Going back to the side effects. Ecchymosis, which is quite rare, and hematoma even more rare. In my experience, just with 200 micron fibers with more perforating capabilities. With the 200, you discard the vessel. So we just got one case of real hematoma of the neck, very, very painful, because the patient feels pain and discomfort. Also for the functionality of the neck, 200 microns fibers. So erythema, benign, after 1-2 hours disappears. If you have the red traffic light, erythema, this lasts even a few days. And you see the patient management is going to be different as well. Edema is not visible, sometimes worsening the initial conditions. The second day, the patient is swollen, more swollen than she thought to be. Is rare, but just for very, very intensive treatment. Well, this may play honestly with some edema, just keeping the starting condition, so masking or changing the real results. So we need the edema to disappear. This takes a few weeks in general, and the patient does not see the real results. So pain is intra-op pain, extremely individual pain, feelings have to do a good pain management, so the patient is more sensitive to the power increments from the pain viewpoint and not to the T-on elongation. So you wanted to increase the power. In a patient very sensitive, you have to work on T-on mostly, because from the biological viewpoint this is more effective rather than to increase the power. Vice versa, if the patient feels pain, you lower the watts down to the threshold, the initial threshold you wanted. You work on T-on to compensate, to find the trade-off, and finally at the end of this game, the energy delivery will matter for the good result. With high energy, high watts is like just burning a food with a flame, and low watts is like a mean cooking something at a low heat. So we're not interested in carbonization, no way to use high powers. And then two new concepts, coagulation and vaporization. These lasers wants to get coagulation and not vaporization. So a more constant, slow, prolonged energy delivery and more effective than some just flames or quick blazes of fire. That's the video of the technique, so I'm showing you now. The eyelids, the jaw. So, as you know, he is the most well-known, the joke line. So, 300 micron fiber. So, retrograde emission, just retrograde emission, or energy delivery. I don't like to go in a so sensitive region with the laser light. I prefer to make use of my hand to overcome harder points, and then I go inside more slowly, retrograde, and also pulse with the pedal, 3 or 4 pulses, and then I retract. Even this time, I want to give higher stimulation. That's one of those regions. If you go beyond the benefit, you can also have some real worsening because you empty. There is a sort of atrophy due to the contraction and reduction of the non-fibrotic component of the tissue. So the concept is stimulating and not traumatizing. I use so low frequencies powers and T-on, 1.5 watts, 20-25 T-on. Robbie, what do you mean? I start with the setting with 3 times the starting T-off. 204 the lower eyelid. Pros and cons. Can you make use of the microphone? Thank you. So yeah, you just lower than the eyelid. The lower eyelid is very orbital. So now the lower the fiber gauge and the lesser the energy dispersal in the surrounding tissues, not beyond the 300 microns, but this depends also on your manual skills and dexterity. Well, just the tiny details about this technique is surprising. The patient has open eyes. I prefer the patient staring at me. I tell the patient, look at me, look at my nose tip constantly. What I prefer is to avoid the patient to rotate her eyes downwards because they want to look downwards if you see the light. If they close their eyes, okay, they look at me. Some manual skills to avoid any accidental laser emission when the fiber is outside the tissue, but when the fiber is inside and the eyes are upwards, we working totally safe. I do not do any anesthesia in this region. This happened to me to do these in very, in scared patients, fearful. With the 25 gauge cannula, I get in from the side, and it be 0607 cc lidocaine diluted 1 to 3, and I inject 1 cc for each eyelid. I didn't get you well. I do not do any anesthesia in fearful patients in reason of the area. Sometimes I do some infiltration, sometimes with the filler cannula, 2.5 syringe, dilution 1 to 3. I just try to be very dry anesthesia. To be on the safe side, I mean, that's what I mean. No here, so we can't hear him. So in these first passages, there is a sort of retraction. Outer mic, sorry, we can't hear him. Submuscular now. Outer mic. So if you go in this region, in the zygomatic region, it's very easy. You hear the clock and the fiber trespassing the muscle, and then you find the plane. I seldom go superficially when we have some wrinkles, and when the patient wants to have a good treatment of the tarsal region and to go under the bone, it's going to be very difficult. I superficialize, and the 200 micron one is safer, because on the eyelid between the skin and the muscle is not that easy. Totally, so I don't know, 20, 25 jowls, 30 maybe. You do more than this? So we have no clinical endpoint visible afterwards. So the erythema shows quickly, you see some contraction. So I'm treating now the part with some laxity. So for festoons, this works quite well, and also I also have a good response for malar bags. You don't have real alternatives to choose. Even though that's a very delicate region, as Alessandrini said, from the lymphatic viewpoint, it's easy to damage it. So festoons are very delicate. We have to play on defensive. One question. Out of mic. No mic. So, starting from the condition that what I try to do, it's a stimulation with no lipolytic effect. It's not a treatment for fat bags. That's a treatment improving through physium. By nature, it's a method stimulating a sort of regeneration. That's a waste of time to hit too much, and edema is less important than I thought it used to be. When I use less energy, I was a bit energetic, and edema lasted even 20 days. Now, the edema is quite benign, 24, 48, 72 hours, not longer than this. A very short edema. No mic, no mic. We can't hear the answer. Why? No, hold. I mean bags. I know why you're asking me this. I know why you're asking. That's right. Since I'm not a doctor, she's a journalist. So, fat forming the adipose bag is very deep behind the septum. No way to go to the septum, so we can have an improvement indirect of the adipose bag because we increase the confinement of the containment of the anterior wall. If we increase the containment, we do not see it so well. But this is not being reduced. I know someone saying I do some retroseptal intraorbital treatment. That's crazy, but this is not for this kind of bag. So if my followers asking me something about the Endolift for the periocular area, you have to say there's rejuvenation, the periocular area, reducing skin sagging, but not the bag itself. Just pushing the bag backwards. Pushing the bag backwards. Yes, good. I got you. One question. Very interesting. In my view, so often it happens to see patients with hyaluronic acid in the SUF area with malar edema. Do you have any experience, or do you think there is an indication? For this case, we made just a small protocol. So the first approach is hyaluronidase. If we have a filler, I prefer to remove the filler with hyaluronidase. What's happening? Maybe you notice it. After you empty the eyelid, there is this filler-induced tumescence. Long-lasting, visible now. Once you empty it for inflammation due atrophy a couple of years or for the immediate emptying effect, you have a quite good tone. And these patients are not happy. And at the same time, after 2, 3, 4 months, there is a recurrence of the tumescence because you didn't take the filler out fully. So Endolift. Hyaluronidase doesn't go beyond a certain level. And then, with this atrophy, so the situation worsens. So Endolift can remove the filler. Hyaluronidase, first step, Endolift, and then regenerating products, injectables. I use these hybrid complexes of hyaluronic acid. They work very well on the eyelid, thus helping me with Endolift to the area region regeneration. Good.
Yes. Ok, we don't read... scusa. No, però magari per lui era meglio perché nella traduzione ha perso...
All'italiano.
Allora,
Maybe he lost something
noi abbiamo una
with the introduction.
riduzione
So we have a
estetica
sort of
della
aesthetic
borsa
reduction of the
legata
bag
all'aumento
due to the
della
increase
capacità
of the
contenitiva dei tessuti
containing
superficiali.
capabilities
Ma
of
non
the
abbiamo una
superficial tissues, but we do
riduzione
not
del
have
volume del
any
grasso.
reduction of the fat
Quindi,
volume.
la riduzione
So
estetica
we have
c'è,
a static
ma
reduction,
non è
but it's not a
reale,
real
è
one.
legata
It's due
all'aumento
to
del
the increase of the
contenimento. Non
containment,
possiamo fare una
because we cannot make any
diretta nella
lipolysis
borsa in quanto
directly
retrosettale,
into
ed è
the
questo
bag
distretto dove
because
con
it's
Endolift non dobbiamo
retroseptal, and we don't have to go to this area using
Solo con
the
Endolift,
Endolift. Never go to this region.
Volevo sapere,
I want to know.
is it
È chiaro? Ha capito bene? Mi hai seguito? Ci scusiamo, ma continua a parlare fuori microfono, non lo sentiamo.
correct?
Sì, proprio così, giusto.
Yes. Perfect. This is absolutely correct. It's the same approach.
Però il microfono non funziona, credo. Bisogna...
Dimmi Chiara.
Allora, sì, in realtà più di una domanda.
Chiara,
La
a
prima,
question.
abbiamo
So
visto
we
che
have
in
seen
alcuni
that
casi
sometimes
selezionati, quando il
with
paziente
selected
si sente un po',
cases,
si fa
so
un'ipoglia anestesia,
we do some dry anesthesia not to get any heat
Più però i
dispersal.
tessuti sono inibiti,
But
più chiaramente
the
c'è
more
contenuto
imbibition,
d'acqua e quindi
the higher the
più
water
energia
content
viene
is,
assorbita dal
so more
tessuto.
energy is
In quel
absorbed
caso
by the
voi, a
tissue.
seconda del tempo in cui
According to the
lasciate la
timing
tumescenza agire, cioè la tumescenza,
and
comunque
according to
l'anestesia
the
agire,
action of
modificate i parametri iniziali,
tumescence
semplicemente
anesthesia, do you verify the initial parameters, you decrease or you increase, like those you would have used without the anesthesia?
È una risposta multipla.
That's a multiple response. So, I mean, if anesthesia makes it possible because of wash, because sorry, I wish to do this. If I want to increase energy, I do this. So the festoon, very well. Mark, I can do something else. So in the more zygomatic part of the festoon, I slightly increase or increase the quantity of total energy emission slightly higher, just telling the patient that the sequelae will be different. But when you do the anesthesia, you're just suggesting the patient not the classical stimulation, but something else. Otherwise, if it's just for the patient comfort, and if I want just to do something quicker, I usually keep the same parameters. Okay, the second question is this one. If the fiber breaks, you have two broken fibers in your series. The fiber is radio transparent. How can you find it again if it breaks? How can you go and find it again when it broke? So I mean, so the thinner the compartment is, the easier it is. If you are in an important adipose compartment, not very superficial, it's also impalpable, not just invisible. And so, with small coarctation movement, you make this go. You make a micro incision with one 18 tip needle. You superficialize and let these get out. The case of breakage in my series, they belong to my very first period. I know a huge work has been done just on the production of fibers, because in my view these fibers are very well structured. They are very, very strong. And since we had this huge change, we didn't see any broken fiber. Never reported on. Third question is about
alla punta della fibra.
the tip
Noi
of the
abbiamo
fiber.
quasi tutti, penso, in
So
dotazione anche dei farmaci di
also we have
ceramica.
some
Premesso che
ceramic
chiaramente durante il
tips.
trattamento si staglia la punta non è più
During
sterile,
the treatment, the
diventa
tip is not
impossibile comunque
sterile,
proseguire
so
con quella
it's
fibra,
impossible to
bisogna
go ahead with
toglierla.
that fiber. We
Ma
have to
sulle
change
fibre
it.
multiuso,
Before
dove
multi-use
chiaramente si
fibers,
può
when we can
sterilizzare ed
sterilize
utilizzare in un
and use
secondo
them
momento
later
questa
on,
fibra, il taglio con la forbice
so
in
the cut
ceramica
with the
dà esattamente
ceramic
la stessa
scissors, is it
garanzia
providing the same
di
guarantee?
passaggio del laser
So the laser gets through. I've not large experience. Now we just use the disposable fibers. We just dispose the disposable fibers. We don't use multi-use fibers anymore. When we used multi-use fibers, I give the mic back to my colleague. Well, now, it's important to say a few words. So multi-use fibers, they still exist, and we use them just in liposculpture or laser lipolysis with cannulas, because they are coated by the metal of the cannula itself, thus avoiding them to break. Also in case of bigger gauges, 1000 micron fiber is indestructible if you ever use it, if you've ever seen it. So lapping, so mirroring effect, so lapping, which is distinctive of disposable fibers versus, sheared fibers geometrically with the ceramic scissors, well, these makes a potential loss of 20-30%. When we use continuous pulse with wattages higher than 6 watts, these entail the formation of a deep carbonization. In specific case of the Endolift, without anesthesia, it's impossible because the temperature, even the pulse, even the pulses under 100 milliseconds, the temperature goes up immediately. So outside the body, more than 100 Celsius degrees, not to do, to avoid. So we repeat, multi-use fibers are reused just for lipolysis, monitoring the possible degree of carbonization, getting rid of the burnt cap, using a surgical knife sterile inside the cannula. Also in liposculpture, we do see some migration towards disposable materials with a lapped tip, giving so carbonization that cannot be compared, much lower than the other group. Last but not least, question. So first you said that also in laser lipolysis should be suggested to make use of a small cannula to take the oil out. So since we have seen mean invasiveness just require a 25 needle to push the fiber in, I have no experience in taking the oily material out with the filler-like microcannulas. I use the cannula for lipofilling. They are thinner, but much bigger than a 25 gauge. Maybe you misunderstood. I also use the lipofilling cannulas, 1 millimeter, 1 Mercedes. Not filler cannula. I use the filler cannula when I do the infiltration. Okay, got you right now. Thank you. I have a question. We said there is some inflammation and inflammation. We speak of the third inferior of the face with liquid, oily, and inflammatory liquid. Since we have the chance of making a drainage more effective than a drainage manually made, is it positive in your view? And what about the timing? So when can we do something to make a very effective drainage in spite of its execution? Well, drainage must be customized. So according to what you see the results, you have to choose the right timing. As Dr. Forte said and other colleagues, I want to to make a sort of lymphatic exercise, one led. We have no time limits, no time thresholds when to start this drainage. We have no time constraints. This must be customized. That's a matter of a few days. Very often I can buy entomology. Just a few days. Entomology. I start the next week after the treatment. I always go with entomology. We need some stabilization the very first day. The patient has these change, sensitivity. They don't want to be touched on because they feel something unchanged on their face. And then goes away. Also to have a better control, I ask the patient to make some entomology, some manual drainage, and that's it, and fix the problem. But edema is not clinically important. I don't mean edema. I mean to drain in an anti-inflammatory way. So, angiomechanics, that's the method I use. From day 3, I go. I use the same technology as Riccardo does. Entomology for body and face treatments. Entomology is the occasion to review the situation. Then we do some drainage, which is usually done by the physiotherapist. This changes over the days. At the very beginning, we have very easy drainage to get rid of hematoma, and then I work on the connective tissue when I see the edema shrink. So entomology makes it possible to stimulate tissues as well. Well, when entomology is over, I just ask my assistant to make a drainage, and I use a special dressing, a containment dressing. So elastic dressing is very well suggested. It's very interesting, and the patient likes this. It is elastic dressing with some adhesive template around the ears, and they go home with these templates. This sort of dressing. Quick now, because I'm not meeting the schedule. So indications you can imagine. Little or mild adiposity, skin laxity, and also little refinements. The secondary cases approach for liposuction or remodeling. I do some refinements because they have some problems because they lost weight. And so little refinements, and that's just a device like a sizzle, easier than the surgical refinement itself. That's the liporestoration, which is more complex than a cannula. You do small areas, and then you just go and smoothing some irregularities. Difficult areas, very interesting, because ankle, so liposuction is not that easy for the ankles. With Endolift sessions, conservative sessions, we can achieve pleasant, nice-looking results without any discomfort for the patient. And also some indications, surgical indications, we treat with Endolift when the patient doesn't want this kind of surgery for personal or clinical reasons, whatsoever this might be. Technique details, maybe we're going to talk about this when we're going to be live. I always prefer superficial lipolysis. Since we speak of a small reduction, superficial liposculpture with the laser is more effective than one deep one, because immediately this changes the profile, the contour. No way to go deep. The superficial plane is useful for the dermal stimulation for the body. I prefer crossed passages, but quite superficial always, or cross-tunneling. So cross-tunneling, as already said, cool during the treatment, schooling. So once we did one side, then we go to the other one. Usually do not treat more than 200 square centimeters per area, 10 by 30, 15 by 20 area as the size. Bigger areas are not bound to Endolift. We're to switch to liposuction or lipolysis. Well, maybe too far now. So protocols, one session or more than one, with this Endolift approach. The one-shot approach is the best approach. Most pleased to patients. Sometimes instead, for more complex indication and also to reduce. So the session workload, we can also plan very, so multi-sessions. So 3 months for one session and the other. So 3 sessions will take one entire season at interval of 3 months. Elastic compression for the body for a week, also less, depends on the treatment itself, and also the change of the fiber. If I have to give you some average values, we change the fiber every 1,500 to 1,000 joules, but this varies. When we have some early wear and tear at 1,000 joules, we change it, and if we treat some adipose compartments, not so fibrotic, with the same fiber, we go up to 4,000, 5,000 joules, no problems. Benefits of this method. So, safety profile, low downtime, medical management with all the limitations this involves. In medical surgery, when you do small talk, and if you can do filler, you can do Endolift. The learning curve very quick to get brilliant results for excellencies. So we need some cases and to be more sensitive. No one can give you, but you have to do this with your hands. The other plus, so the control of the results, stable results for adiposity. So once you remove the fat, this will never come back, and also have to make some maintenance. So once here, as to skin tightening, because the contraction has to be kept, because it's going to be lost. Why fat reduction is going to be stable over time. I think I did everything. I would like to add on some benefits. This therapy can also be done in summertime. Yes, absolutely. The epidermal reaction is a minimum, even though we go beyond the threshold of the yellow traffic light. Absolutely, also in summertime. And also for darker types. No hyperpigmentation also in dark patients. Dark-skinned patients. May I say a few things? I want to add on my personal experience as to the Bori treatment. So this selection I do at the very beginning. I speak of the Bori treatment. If I have to get rid of any adipose tissue in excess or not, or if I just have to treat skin laxity. Sometimes we have patients, we see patients coming to our office with mixed problems. We have some fat in excess in the tissue which is not tonic. A few years ago we would have said, no, you're out of age, so we can't do anything for you now, you're too old. No liposuction is going to be safe. Thanks to Endolift, I went beyond this, in spite of our patients' age, because what they want to get from us is sort of compromise, a trade-off between fat reduction and the tone of the tissue. That is not to be any worse. I proceed this way. I start with the Endolift. I do some dry anesthesia, very superficial, very often. I just work with air cooling in this air. So I just work against the deep derma. I'm very superficial. I superficially go with this fiber because what I want to get in the end, that's what Dr. Forte just said a while before, is the 3D compartment. We have to be near the Camper fascia and the fibrous septa, near the fascia, to have some compactation of this district, of this region. This is impossible if we take the fat out. So if we try to recompact the septa, but the adipose tissue is still there, computation will not be good. So we have to work on these two sides. For these patients with a mixed skin laxity and adipose tissue. First, I work with Endolift with some dry anesthesia, and once I did 1,000, 2,000, 3,000 joules, large areas also. I changed strategy. I work with lipolysis laser with the tumor center anesthesia, and so now, I want to get rid of fat. In one shot, one step intervention. I do two things. I take two birds with one stone. A sort of synergic effect. So capitation is not possible if we do not eliminate fat. At the same time, one-step procedure, yes. Outer mic, yes. One-step procedures. It's always good to plan a good timing with Endolift, because we work on very thin regions. The more virgin the tissue is, and better the use of the fiber. Outer mic. So, I mean, why skin tightening and then you remove the fat? Why? Skin tightening is not done immediately after the stimulation, after some months. But the skin tightening is done if I get rid of the fat as well. I have to eliminate the fat because I have a sort of reassembly of that area after removing the fat. Yes, I got you right to this point, but maybe from Della Banzata's presentation it goes the other way around. First he removes the fat and then he uses the Endolift. I was not saying about Endolift anything. I said skin tightening. If the tissue is very thin, so it's much better to make the tissue tightening with the Endolift. When the thickness is much thick, you can just have a sort of fair play. It's not key to do these before. You can do the two at the same time. First, Endolift before any other method. Because when the imbibition is local, it's more difficult to make a very effective Endolift. There is someone asking a question just at the bottom of the room. Can you pass the microphone to the colleague with sight glasses? Can you just raise your hand so I can see you? Well, thank you for this presentation, excellent presentation. I want to ask to the panelists, we have cases where the volume of fat we have to remove so this is just for surgery, real surgery, but also we have the skin tightening. So the question is this one: do you have thoughts or experiences so far to combine these two protocols with surgery? So the volumes obtained with surgery and this new approach for skin tightening. So, you mean face or body? Viso o corpo? Corpo. Yes. So, I mean, this has been fully described, these combined approach to skin tightening and surgery. Bhavani said of this combination, first step is skin tightening with some anesthesia, dry anesthesia. Second step, liposuction sculpture, more or less laser assisted. You can also combine with the traditional liposuction. And second step, for the volume, I mean, reduction. The parameters are the same in skin tightening. And the second surgical step, so according to the way, according to the device by the operator, yes. Synergy, yes. I would like to end with you.
mini
face lifting for energies, and also Endolift as a complementary approach. I'm asking the colleagues making more surgeries than me. Lifting, no. With the remodeling, volume remodeling, yes. For volume remodeling, yes. Usually, I do the laser lipolysis emulsion with ultrasound of the areas where we have more volume. I totally change the setting, and now, at that time, I go and turn up the tissues. When I decide to do these in the same surgical step, that's very important. So the patient, shall we treat once or twice? Should the patient undergo anesthesia once or twice? So I give priority to Endolift with the settings for a good Endolift, and after that I change the setting. I just give more anesthesia if need be, and I just take the fat out. May I tell you a few things? As we already seen earlier on, we have a lot of troubles, a lot of problems, so you know what I mean. For many of you, being aesthetic doctors, they have to use the Endolift for giving a more complete treatment. Also thinking of emptying, filling. I'm thinking of traction threads. So another techniques, we have to include these Endolift, this technique to get better results, achievements. Or the platysma, botulinum toxin. When to use Endolift in more complex protocol, I think that's really interesting. Absolutely, you're right. Absolutely, you're right. These protocols, in a way, are very, very exhaustive. So preparation with botulinum toxin, with the platysma. I do these on a routine basis for thinner necks when platysma is more visible, and also a combination with fillers as well. So of course volumizing effect of the medium third, superior third with the equation of those deep pillars, supportive pillars. So I do at the same time with the Endolift, first Endolift and then filler, or after a few days after the Endolift. I try not to do the filler before, because if I want to go also in the third inferior area for some, refinement, I'm going to spoil. So traction threads. So we speak of these traction threads. I prefer saying stability and not traction threads, because you can get traction with some very, painful sequela. After some days, 15, 20 days, or even longer than 20 days after Endolift, so threads. I may use threads with some anchorage to stabilize, to help compactation. That's quite effective in my view. These threads, just going backwards to the lines of the Endolift, so using these threads, making this compactation easier. It's going to be very beneficial in my view. Okay, these are the protocols I use. As to the buccal angle, you reach the mandibular ligament. I trespass this ligament with the fiber. I go up to the median line sometimes. That's quite difficult area. We have to pay attention. We have to be careful. When I go through this region, I go, so we retrograde and not anterograde approach. Not many passages, just a few, to have a sort of symmetry effect. My feeling is, also for the neck, sometimes you have also a stimulation at the fascia level. It's not your target in theory, but we have some improvement of the platysmal band. And it's not the muscle, but also the containment system is good, is responsive, because you see some picture where the platysma is very small, but we have no direct action on the muscle containment. So sometimes I want to give this stimulation in a more direct way, and for the lower part, you go above the thyroid. Okay. Sometimes I go laterally. I go down the sternal plate, but we have no efficacy. Maybe you see these over the time as a thermal remodeling. So we speak of wavelength, which is used by the non-ablative fractional lasers. So we speak of thermal remodeling, regeneration. This actually does the same stuff. So as the non-ablative fractional laser, which is found in the machine kit. I also use the fractional laser, and I use it a great deal, in spite of Endolift, also combined with biosimulation, so a strong impact, but also for the Endolift, the lower part of the neck. I finished this off using the fractional laser. I also use the CO2 fractional laser in the same session. CO2 laser can be more impactful, but we made this sandwich effect with the Endolift and then with the non-ablative fractional laser. So we need a different setting, which is not the one of Endolift. So 3 sessions after 2 or 3 months, one from the other. So the periocular region, fractional laser is fantastic. One question from the room.
Poi in fondo alla sala anche, grazie.
Sorry, it's me again. And then another.
Perhaps it's me, but I'd like to clarify 2 things if possible. First of all, when we say Endolift, what exactly we mean? We mean tightening of the skin on the face or everywhere in the body? Ed, the way I understood, if I'm right, with Endolift, one of the main demands in practices is the laxity on the jawline, of course. And there, we cannot do liposuction, or it's more difficult. So we can do Endolift just using the fiber on its own without any local anesthesia because it's not painful. This is the only reason, because it's not painful or because it is more effective. Say, for example, I like to do some minor anesthesia just because the patient is very sensitive, 5 or 10 mL. Will it make less effective the treatment? No.
No, assolutamente. Ok, scusate. Parto dalla seconda domanda.
Can you translate the question from the participants?
È chiara la domanda del collega. La prima è se
Did you all understand the question? The first question,
solo la finalità di ridurre il dolore,
anesthesia,
ma può in qualche modo
just for pain relief, but anesthesia can also affect the outcome, negative or positive outcome, as we said. So, if it can change the biological effect, I have no certainties. I don't know. I believe it's quite, doesn't matter. Above all, if it's a dry anesthesia, as the colleague said, a minor local anesthesia, so we do these just for the patient. So the method can be also good without anesthesia, so Endolift originates without anesthesia, but anesthesia is also possible when the specific conditions of that patients require this. The other question was if Endolift just skin tightening and lipolysis. Endolift is the application, there is a special wavelength in remodeling, in face remodeling, including skin and fat if necessary. And Endolift so also wanted to have a really invasive management without anesthesia. And as we said, lipolysis, we try to do this when it's necessary. I do skin tightening in this region and skin tightening and lipolysis in this area, just changing the parameters.
It's not necessary.
And the fibers, e anche le fibre. Non è necessario, non è necessario. It's not necessary. Altra richiesta. E quando ci sono ovviamente cuscinetti di grassi e anche lassità, cosa si fa? Sempre la fibra da 200 o facciamo la lipolisi laser con la canula? Come procediamo? Un po' non chiaro. Ho una macchina che ha, diciamo, le due capacità. Con la stessa macchina possiamo fare l'uno e l'altro. Allora come ci comportiamo? Utilizziamo due fibre diverse o la stessa fibra con settaggi diversi? You can use the same fiber with different settings to have a selective action, skin tightening and also lipolysis. You can do with the same fiber, which is at least 300 microns. With the 200 microns, it's quite difficult for lipolysis. If you just mix the treatment, I choose the 300 micron fiber and set up the machine for skin tightening. On under 50 milliseconds for those regions where you do not want to treat the fat, and then more on if you want to make lipolysis, and then it stops. If in your cultural heritage, in your manual skills also have, surgery, you're also a good surgeon, no one asks you not to suck after the laser of using a traditional liposuction cannula or a cannula already foreseen to make a laser lipolysis and suction at the same time. But that's a plus you can decide to use if you have the necessary skills, because these participants is made of not just surgeons but also colleagues who use the traditional Endolift, or maybe, I repeat, if you have the manual skills, you can safely use it with a surgical approach, combining with surgery. I would like to add on something. There is one study, a scientific study, I will send it to you, the threshold, daily threshold of the destroyed fat, 1,800 calories per day. That's a cutoff value for simple laser lipolysis versus the liposuction we do choose. That's very important. When you're just under 300 cc, you can just make you can make this choice, because your body or the body makes this metabolization of 1,800 calories per day. We have a question at the bottom of the room. And then on the second row. Thank you all. Grazie per questa esperienza. Mi sapete dire niente dei cuscinetti di grasso della palpebra inferiore, e soprattutto avete, diciamo, delle esperienze di trattamento della bolla di Bichat? Ecco, volevo sapere questo, grazie mille.
Okay, for the first question, maybe we are not... per la prima domanda non siamo...
Per la prima domanda,
okay. Per la prima domanda
devi parlare in italiano. So the first question, she wants to know something about the treatment of low pad in the lower eyelid. Maybe we were not clear, but the fat on the lower eyelid, not the lower region versus the lower eyelid, but just the lower eyelid, that's posterior region. Vis-à-vis our treatment. So this treatment is not a direct treatment, but the result is achievable by the indirect treatment on what is above the eyelid, because the anatomy of the lower eyelid is given by the skin. The skin is totally attached to the muscle. We have no hypoderma in the lower eyelid. So we've shown you some pictures. So there is a sort of a complete adhesiveness. If we do not detach, that's the main topic for the next period. If we don't have a detachment of the skin vis-à-vis the muscle, we cannot work on this thickness. Under the muscle also we have the septum, the septal part, and under the septum we have the fat you said of. So we are above this compartment. We do not intervene on the adipose or fat bags. And second, you said something about the intrabuccal fat of the B-Shas pad. I have no experience. I don't know. You have any experience? No, we have no experience. I don't like to get rid of the B-Shas pad. But these regions have to be treated with open approach, not covered approach. We have to go with the fiber when we know where we're going to work with this fiber. Another question. I want to ask you, I'm looking at this picture,
prima e dopo.
So, first and after. So, personally speaking, I don't like this after situation. So, my question is this one. Is it possible to intervene once again? And if positive, do you get an additional improvement? So, vis-a-vis the after. And how long does it take me to re-intervene, to do something again? So the immediate result, maybe you don't see the wording, the immediate result, just to make you understand that the patient leaves the surgery this way, but the clinical result is visible after 60-90 days. And then it keeps on improving up to 120 days. That's the immediate appearance. So maybe it's not really rewarding, but in reality, so I think this result is quite meaningful because 20 minutes from the first picture and the second picture is really rewarding the patient, but this is not really a result. With some collagen coarctation, which is not lasting, and also with some edema of the jaw profile, and so it's a sort of deceiving effect. I'm showing you these photographs. I'm showing these photographs to our patient as well. What the patient has to expect after the treatment. You see on the jaw line, you see, I don't know, can you see it, the jaw line? You're a bit too far. Can you see this erythematous area? That's something to expect. Very marked, more diffuse erythema with some more eye-catching marbling. That's the second step we were referring to when I told about the yellow light, traffic light. So this result, how to say, is really well appreciated by the patient. If we retreat, we can see this much better, but not right away. This will take some time. So the situation is to recover quickly, but not before 3 or 4 months. I don't know if you agree with me or if you disagree. Many sessions with some cumulative effect, but timing is the timing we already said about. That's the time we need. I go back to the same idea. This result can be more or less satisfactory, but I have no other method giving you this kind of contraction in 20 minutes time. It will be with very well placed traction threads, but how long is it lasting using these traction threads? So, the patient would be happy with this result as the final one. To get these in 20 minutes with surgery, no way. But I was thinking of something. During the treatment, according to our experience, are we changing, or do you change the cleavage plane, changing the power? So, when I see a lot of adiposity, can I go deeper with a higher power and then I go up to the surface? Well, we're going to answer you both. So the thickness in the cervical-facial area, just a few cases, the thickness is never so thick to give problems or different depths. When the fiber gets in, we speak of millimeters. We speak of fatty skin with a lot of fat. So, and then I go back to the question asked by the colleague. Maybe when you have two targets, fat and skin, So manual skills and setting can change or make the difference. And one passage, so medial superficial, but superficial on the fat, and then an additional passage, a second passage, with reduced low fluencies, trying to be very close to the derma, scratching the derma from the inside. That's a good approach. That's a good way to go. I'm doing this above all for those regions being very fatty regions with a lot of fat. The only area when I just pinch and with the tissue and with the cannula I go downwards is the submental area. I pick up the fold and then I just clamp different thicknesses. In that case, yes, I go and look for different planes. Something important, in the neck treatment, lipolysis of the central part of the neck sometimes is very effective. So effective, lipolysis is to make a problem, because sometimes we see the platysmal bands which were not visible before. So the patient said, okay, I see myself very well remodeled, but I have these two folds. So these were still there, already there, but they were hidden, concealed. So we have to tell the patient that lipolysis gives rise to different anatomical definition, a contour. And not everything is going to be like the two medial platysmal bands. Now, quick, sorry, out of mic. Sorry, out of mic. So, these are some questions. They need some explanation. Each question will deserve a full presentation, each of them. The time is running out short. So for malar bags, that's one of the most difficult areas. So being very much rewarding. We have to play on defensive this area, because as the colleague just said, it's very difficult from the lymphatic viewpoint. So we have good results for malar bags. What are you saying? I mean the fat above the nasolabial area. There's a fat deposit. How do you treat it? So the nasolabial fold. Others name it or call it malar bag. It's not a malar bag. It's the nasolabial fold. How to lift this up, you mean? Or reducing? You want to age the tissue? What do you mean? I didn't get you. We made the skin tightening. We do not make any lipolysis. You cannot make the patient look older. If you do lipolysis on that area, the patient will look older. For the eyebrow, that's a good suggestion. The eyebrow, to lift up the angle of the eyebrow, that's one of the indications for this technique. With the fan treatment, one access treatment, just to lift the eyebrow up. It's more conceptual than practical. In retraction, with tiny spots, like small traction pyramids, just to lift the eyebrow up. If not constitutional, because many have just a constitutional fold, but very often this is due to a sort of fat dislocation the emptying of the malar area. So the first thing to do is to reconstruct the volume upstream. Sometimes the patient comes in, I would like to get rid of this wrinkle. So the problem is upstream, so a sort of top-down approach, not bottom-up. We have to recover the volume in the anterior lateral area of the malar area with filler or lipofilling, depends on using filler or lipofilling. Last but not least, also for the entire group, I've seen the barcode. That's a question always we have to tackle with our patient, barcode. So fractional laser, filler or endolift, which one? All the three. In alphabetical order maybe. Like a school. So barcode is difficult to treat. We know this by heart. So the approach is mimic wrinkles, expression lines. I want just to get rid of these expression lines. So mimic wrinkles. Botox, so it just reduce the traction of the muscular fibers. I go down into the derma. Barcode wrinkles at rest, filling using the filler, mimic wrinkles, the structures, total deep volumization. Any use of fractional or fiber laser, these must be done before all this, I said. I already said while opening this workshop, but I believe that's a concept that has been very useful in my practice. We have some excellencies, and the lift is doing something very well, and the lift is our first choice. But since you have it at your disposal, you can have fun and do a lot of different interesting things. But and that's my way to answer the question about barcode. The stimulation with subdermal fiber in a way can help with the barcode. It's not sufficient, but that's something helping us. Of course, I would never buy Endolift for this kind of indication. It's not a method for the barcode, but this can help. And also for scarring, so acne scarring tissue. We've seen this already. That's a secondary list of indications. Endolift is the only machine available making such and such things. And that's our first choice machine. It's very versatile, easy to use, easy to run. And you're saying a lot of things. You're saying a lot of things. We didn't do all things we're doing today, and we'll find many other things out. Let's focus on this. Endolift is unique. The barcode, yes, that's a special, very sensitive area. So the only area where, so I don't like to do anesthesia with Endolift. For the barcode, I should suggest some local anesthesia, and then the fractional laser in the same session, after a few days, after a few weeks. So I just supplement with the Botox or hyaluronic acid according to the type of wrinkles. So now you see first and after some views, some pictures. It's not the average. I mean, these are patients very responsive with special applications, happy results. These are the potentials of these machines and the lift. So I ask you, shouldn't this be good to have the same results? You see the follow-up after 1 year. The regeneration is very interesting, regenerative effect. And my friend Michela, the journalist, asking questions, she already said this result is a real result because she published this result showing her personal photographs taken by herself. We didn't take her photographs. This is just the Endolift machine. So we said body. Now I'm going to show some video clips just to have a lively discussion, maybe. So you can also be more motivated in order to combat fatigue before lunch. Can you give the microphone to the colleague in the room? I want to ask you, any experience about the treatment of stretch marks? Also empirical experiences for the treatment of stretch marks? Yes. At the first training, many years ago, we always suggested to start with stretch marks, because you can never try in this region. You have your wife, your girlfriend, and they have stretch marks. You can start and learn how to hold the fiber under the skin. That's an area where you can never try. And to try your skills, to learn. You do not learn just using preceptal fiber in the lower eyelid. Maybe you can learn this, putting the fiber in the body and also into the stretch marks. For the efficacy, so we make a distinction between red and white stretch marks. We combined this with the Endolift treatment, but not inside the stretch mark, but we go perpendicularly to the stretch mark. We want to remodel also the edges of these stretch marks, and then we do diffraction laser on the top of it, which is provided in the machine kit. So we use these two all together at the same time. Combined treatment. I see the several body areas. For the lower part, which is a bit heavy to treat, troublesome, also for the presence of skin laxity, fat and cellulitis. For sure it's the most difficult part of the body ever. We have to use the synergy of many devices and injectables. I believe combination Focus US, Endolift and injectable stimulators, that's a good cocktail that always works. One single treatment is not enough. And above the knee, so above the knee, okay, I think that's an area that gives us excellent results. So we have a fiber, 200 micron fiber. Is it 200 micron? Yes. I prefer the 300 micron fiber. It's up to Domenico this time. Domenico works with me, so he likes the 200 micron fiber. That's Domenico's choice. It's more focused, it's more energetic, it's more difficult to handle, but it's more energy releasing. For longer, parts or trips, so the 300 is stronger. So that's what I mean. Absolutely, you're right. Yes, I agree with you. And also see the ankle now. The ankle, which is not very common, but sometimes it happens to have some ankles. And also the subcutaneous banana, small banana, yes. For the ankle, you want to make some also lipolysis, yes, also lipolysis, little lipolysis also for the ankle. Depends on the kind of banana. Emptying, skin tightening. Banana due to fat, an outcome of not a very good liposuction. Depends on. What about sagging? What about results for sagging? These are difficult areas to treat, and you have blunted weapons to shoot, and now we have a better weapon to shoot, to use. If you bought it for the main indication, you do this. This is not the solution to the problem, but it works. And I go back with the combination with surgery. That's an area with traditional liposuction in a way. And so we do the remodeling with lipolysis, with the gentle remodeling. That's a good asset. That's a good combination. Liposuction, and I go underneath with the laser. Also in the trochanter region. So you just go
gli dai
and
il
reshape,
contentino facendo
remodel,
quella
and are
piccola
going to be
rifinitura e
safe.
stai tranquillo e sereno che non
There will never
ottieni
be
mai
some sagging.
un cedimento.
Okay. These are the cases of the body. Roberto has shown other examples. This is without anesthesia, so very, very gentle results without anesthesia. Roberto has shown a lot of examples. Sì, una settimana.
Yes, 1 week.
Okay.
Ok.
And that's it for me. Thank you.
Direi che ho concluso.